Liz, how are you doing today?
Alive, hanging, and it is already summer in Texas. It's already like 100 degrees, it feels like, and muggy. So you're from California, I'm gonna get to rub that in.
I know it's funny because there was a conversation at our meeting yesterday, and everybody was talking about like the conference in July. It's going to be so warm. It's California, and Val was like, "Well, it's Northern California. It might be a little cool." And I just like kept my mouth shut in 75 degrees. I was like, "I'm totally fine down
Yeah,
here." So
I don't know how
I think
y'all feel, but
I think the conferences should
um,
always be in Southern California. It would always be beautiful for y'all that attend, so you'd never have to
yeah,
worry about weather.
and Adam's joining us from the same place, so I get it. I'm jealous, but here I am in my heat. So good to see you, Chris. So good to see everyone. I want us to hop in because we have such an exciting live stream today, and we know that it will be so warranted. We find time and time again that anytime we bring individuals on who can help us talk about medication a little bit, or TMS or some of the new research studies, like there's a million questions, and so we want to make sure we get to those, and that's exactly what we have today. So a couple updates. As always, please remember these live streams are intended to be informational and educational, but they are not intended to replace therapy, and they're of course not intended to help if you're in crisis. So if you're feeling crisis, suicidal, or unsafe, please call your local suicide hotline. You can call 988 nowadays, or of course go to your local emergency room or call 911. Today, again, remember too, you guys, that you can visit iocdf.org/peace of mind. And that's where you're going to see more about our live streams, what we do. But this is so important. This is the place where you can put questions, you can put content you want to see. And, Chris and I have a lot of thoughts, and we would love to believe that we know what y'all want. And we feel good that we try our best to hear you guys and to coordinate, what we think the needs are appropriately. But we want to hear from you. We want to make sure if there's things that y'all want to hear that we're not covering, or specific questions, please put those there so that we can make sure we cover those. We are so excited to have everyone here. So y'all know Chris. I don't need to introduce him. Chris and I both lead these live with Chris and Liz's Ask the Experts, whatever we want to call them. But today we are joined by a special guest, Dr. Adam Frank. Dr. Frank is a researcher, psychiatrist, and assistant professor of clinical psychiatry and behavioral sciences in the Keck School of Medicine at the University of Southern California. He attended UCLA for medical school and graduate school and holds a PhD in neuroscience. He completed adult psychiatry residency at UCSF, where he participated in additional training and research in the neuromodulation treatments, such as TMS and DBS, for psychiatric indications like depression and OCD. Dr. Frank currently divides his time between caring for individuals with OCD in an outpatient clinic, supervising and teaching residents, and conducting research on the mechanisms of OCD and improving outcomes through the use of neuroimaging, wearable biosensors, and neuromodulation. We're going to talk about all of this, and this is all so important. But first and foremost, thank you so much, Dr. Frank, for joining us. We love to have guests on. We know that so many people are going to want you to be able to answer medication questions, and lots of questions about alternative medical interventions like TMS, DBS, where it's at, trials, all of that. So thank you for joining. We're so excited to have you. If you want to share a little bit about you, your background, or anything you think we should know.
Very, very happy to be here. Thank you both, Chris and Liz, for inviting me. Apologies in advance if there's any little bit of lag. I'm in the basement of one of our psychiatry clinics today, and our internet connection is a little tenuous at times. Happy to be here. Happy to be able to help field questions. I know, particularly in the neuromodulation realm, there's people often don't know that these are treatment options that are available, and happy to sort of talk about that, medication, whatever else comes up today.
Perfect. So tell us a little bit about your background in the sense of your training and background, and what I know from your bio what you focus a little bit on, but how would you explain that to patients of what you do and what your expertise are?
Yeah, I think you had a great summary of sort of an overview of the training that I had. So, a psychiatrist goes to medical school and then gets specialized training for an additional, typically 4 years, maybe even longer if they subspecialize in a residency program. And so that's additional training after med school to become a psychiatrist. So I did that at UCSF. And UCSF is a place that has a lot of new research and techniques. And so I had the opportunity then to really get additional training in these neuromodulation treatment options. So transcranial magnetic stimulation, deep brain stimulation, as well as just getting great clinical experience in caring for individuals with OCD. So primarily doing medication management, but getting a little bit of experience doing some ERP in individuals. And then I've continued to hone that practice now as an assistant professor and really sort of focus on caring for anybody with OCD, and particularly people who haven't responded to standard treatments and are looking for other options.
Yeah, no, that's awesome and wonderful. And we need more psychiatrists focusing on OCD and related disorder work because there's not enough of you. So let's start with just kind of a basic question to lay the groundwork, because it sounds like we're going to get a lot into detailed medical interventions today for OCD. So let's start with first line treatment for OCD. So is first line, so we know the gold standard is often a combination of medication and behavioral therapy. Our behavioral therapy, ERP, we focus a lot on that. Today, we're going to focus more on the medication side. Can you start by introducing a little bit of what the current first line medical medications are for individuals with OCD and related disorders?
Sure, I think that's a great question, a great place to start. I would say the first decision is sort of severity of OCD symptoms, how impairing these are for people. And for people with mild to moderate OCD, it might be reasonable to not even start with medications, to just start with ERP. If somebody's got more severe OCD or has difficulty accessing ERP, I think evidence suggests that medications are a reasonable first line. And those are typically the SSRI medications. So things like fluoxetine or Prozac or sertraline or Zoloft, paroxetine or Paxil. I'm giving both the generic name and then the brand name. Sometimes people know them better by one or the other. Escitalopram or Lexapro and citalopram or Celexa. I think I hit all of them. Those are in multiple studies and meta-analyses where studies are combined to really sort through treatment outcomes. Those are supported as effective for people and typically well tolerated. There are other medications that act in a similar manner, but sometimes come with more prominent side effects. And we usually think about those as sort of second line medications if somebody hasn't had a positive response to an SSRI.
I would say one of the questions that I have, what I see, and I wonder if Liz sees this as well, could you talk a little bit about the necessity in dosing in general for OCD frontline medications? And the reason I ask that question is a lot of people struggle to find a psychiatrist or a prescriber that regularly works with OCD. So what I see is a lot of people do luckily get on these first line medications and are finding some relief, but often they come on a very low dose. And it's not until maybe they get with a psychiatrist who understands OCD to get on proper dosing. So can you talk a little bit about like proper dosing of these first line? Because I think sometimes people don't use or get off medication or don't find it helpful, and they may be on such a low dose.
Yeah, it's an important point. We know, so typically for SSRI medications can be helpful in a variety of different conditions. So they're indicated for people with generalized anxiety. They're indicated for people with major depressive disorder. They can be helpful in PTSD. They have a variety of uses. So it's not uncommon for even like a primary care doctor to prescribe these medications. At times, the dosing for OCD is a bit different, and when we might expect to see the maximum benefit from these medications. So for depression, for anxiety, we're usually thinking that we'll see sort of maximum benefit in 6 to 8 weeks. It's unfortunately a long time for somebody to wait, but typically over a month and a half to 2 months, people start to see the benefit there. For OCD, that can be even up to 3 months, so even longer to see benefit. And there are studies that suggest that higher doses than we typically use for depression and anxiety can be of additional benefit. So for instance, a maybe standard dose of sertraline for depression or for anxiety might be 200 milligrams. We may have people go to 250 or 300 or even 400 milligrams of sertraline or Zoloft for OCD, and continue to see additional benefit for their OCD symptoms at those higher doses. And that for generally all of the SSRIs, I would say the exception might be citalopram or Celexa. There's indications that at higher doses that can have an effect on heart function. So there really are strong recommendations. If you're planning to go to higher doses for OCD, maybe consider something like fluoxetine or sertraline or paroxetine, where it overall seems to be safer to push to those higher doses.
Yeah, and the question that I wanted to follow up with, and you kind of touched on a little bit, is what should somebody expect on the medications? What is kind of how okay, the medication is working? Because I think that's another question people have. You take an Advil and it's like your headache goes away in a half an hour, but you talked a little bit about timeline, but with these first line medications, what can people expect, and how do they know they're on the right track and should stick with it, and the medication is working? What can people expect also with symptom relief?
Yeah, I think that it's a really good question, and maybe sort of two packed together that I'll try to parse apart. One is, how do we know, or how does an individual know if the medication is working? And sort of maybe in a related question is like, should you continue taking that medication? And maybe I'll start with the second question, like whether to stay on a medication or not. We know for all medications, there's the potential for benefit, but there's also the potential for side effects. And that's a constant sort of conversation one should be having with themselves and with their psychiatrist, is if I'm having side effects, are those worth any of the benefit that I might be seeing? And that can be challenging at first when you're starting a new medication, particularly for the SSRIs. We usually see side effects way before we start to see improvement. And so I think initially it's sort of managing any of the side effects that might come up. Some of those are temporary and improve with time. And so just even understanding that nausea that's started with your sertraline might get better over the next week or two can help people sort of push through that. But sometimes side effects are really problematic, really uncomfortable, aren't getting better, are getting in the way. And that might be a reason to think about trying a different medication. So that's sort of the, do you stay on the medication or not? And then in terms of benefit, there are some studies that suggest that relatively early on, people might start to notice some improvement. And if they have that experience, that they may then actually go on to have a really positive response over the ensuing weeks to months with a particular medication. And those studies, by the 2 to 3 week mark, people start to notice some benefit. And I think, as you're pointing out, Chris, it's not like you wake up one day and OCD is gone. That's not how these medications work. Typically, what people tell me is that they'll find that the obsessions are still there, but they're less intense. They're not as bothersome, or they're a little less frequent, or the urge to do a compulsion is there, but people feel like they have maybe a little bit more control over waiting to do the compulsion, or not engaging in the compulsion. And those sorts of experiences are kind of what we're initially hoping for people to have, in terms of like more distance from OCD and maybe like a bit more control. And that typically then builds over time. And if people are able to be engaged in therapy, I really think of those two things as sort of synergistic, that some of the benefit people have in terms of like less intense reactions to obsessions allows people then to actually do more exposure and get additional benefit from ERP.
Well said. So it sounds like definitely making sure that that's paired, not expecting the medication to be the cure all, but making sure that people understand that the medication is there to support the exposure response prevention.
Yeah, yeah.
I'm going to let Liz jump in a second. I just we have pre-submitted questions, so I want to get like 3 quick ones in together. The first question is, sometimes people want to know, do they have to be on medication for life? And is there any danger being on these medications for long term? And then second question is, when selecting those medications, is there any kind of testing people do, or is it more of a trial and error experience?
Yeah. So one question is, do people need to stay on meds forever or for life? And then the other is there testing that could help to guide us in terms of, are people on the right medication? And I'm seeing in the chat, I think I forgot to mention fluvoxamine is another SSRI that is commonly used in OCD. So there actually was a recent study that was conducted this was in adults who had been on an SSRI for their OCD and had improvement. And then they randomized people to either continue taking their SSRI or get a placebo pill that actually weaned them off of their SSRI. And about half of the people in the group that were weaned off of the medication, so stopped, did well, continued to have minimal or markedly improved OCD symptoms. And so I take that to mean that in people who are doing well on medication and are interested in thinking about maybe not being on medication or being on less medication, it's reasonable to try slowly tapering that down and seeing how individuals do. And we might expect that about half of those people will continue to do well without medication. The other half of the people in that study had OCD symptoms that started to come back and then exited the study, and I think for many of them restarted medication. But I think that's encouraging that there's really like controlled studies to suggest that many people will do well either tapering or stopping medication. I should say that that's in people who have responded well to medication, who have been on it for a while. If somebody you're still adjusting doses, or people feel like OCD symptoms aren't adequately controlled, that's sort of a different category, and I don't know how people would then do coming off of the medication. I think more likely OCD symptoms might come back. But in people who have done well and are on a stable dose, I think it's certainly reasonable to try tapering and coming off. The second question was about testing to see if people are on the right medication. There are some tests that can look at how your body processes medication, and that at times can help guide medication selection. So for instance, if a particular medication is processed by your body through a given enzyme pathway, and in a particular individual that pathway isn't working as well, that medication can easily build up to much higher levels than we would otherwise expect, and may have people have prominent side effects at what seems to be a really low dose. On the flip side, if your body's processing pathway is really revved up, then we could be at really what seem to be high doses, and your body's just chewing through the medication and processing it so quickly that you don't actually have an effective dose. We don't typically order those tests to start. Those are things that we think about if we've tried, 1 or 2 medications, and again, either we're at really high doses and we're not getting side effects, we're not getting any benefit, or we're at low doses and we have really prominent side effects. It might be reasonable to think about some of that genetic testing to help guide medication selection, but that's usually not sort of at the start ordering testing to pick which SSRI we start with.
Thanks.
So I guess one of the things we should hop into thinking about next is, and I don't know what makes sense, but I'm feeling like what would make sense to start first with is, if an SSRI isn't working, what is the first? So if the kind of standard stuff isn't working, what are some of the first recommendations around augmentation and shifts that people should be thinking about? One thing I just want to remind everyone is that we really, 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 if it's possible, want you to make sure you're working with a psychiatrist who specializes in OCD. This is really important because sometimes non-OCD specialists don't understand the dosing and right. It might just be, oh, they need an SSRI, but they don't they may not know exactly what that should look like for an individual's OCD and presentation. So that's really important. So I just always want to throw that plug in. But Dr. Frank, if you could talk a little bit about, okay, we're seeing SSRIs aren't really helping them move the needle. They're still struggling. And of course, sidebar recommendation, everyone, we should be thinking about your behavioral interventions in conjunction, right? So we shouldn't just be saying, oh, medication's not working, so change the meds. We should also be thinking about, are we with the right behavioral therapist? Should we be changing our behavioral therapy? Do we need it more intensely? I want to make sure we're reminding everyone that the work should be happening together, right? But so if we feel that the medication relief they deserve isn't happening, what is the first augmentation or first next step?
Yeah, and I think that's a great question, and I appreciate the sort of nuance in trying to find a psychiatrist as well as therapists who have experience with OCD. So maybe stepping back and saying, looking at sort of a broad picture, how impactful is OCD? Are people getting the intensity of treatment? I think you sort of alluded to this, Liz, the intensity of treatment that they need to actually have full benefit. And so sometimes, once a week ERP and Prozac isn't enough if somebody's really impacted by OCD, and thinking about sort of more intensive treatment programs, IOP or PHP or residential. If that isn't the situation where somebody really needs to sort of just overall step treatment up, and they're doing okay with ERP, and we're just not getting much benefit from our first SSRI, it would be reasonable to try a different SSRI. After about 2 trials of an SSRI, the chance that a third one is going to sort of be the magic cure is really low. If somebody's had say a trial of Zoloft and hasn't really responded and has gone to those higher doses and stayed on the medication for 2 to 3 months, and maybe we've switched to something like Prozac and also tried to get to the higher doses for an extended period, and they're still just not having much benefit. I think the next option would be a trial of clomipramine, which is an older antidepressant medication. It's in the tricyclic antidepressant family, or TCA. It was actually one of the first medications that showed benefit in trials of OCD back in the 80s even. And is as effective, and some studies suggest maybe even more effective than SSRI medications. The caveat to that is that clomipramine typically has more prominent side effects, so sedation and weight gain and impacts on GI function, and at higher doses and in overdose can have the risk for seizure or for impact on heart function. So it's something that we think carefully about whether that's the right medication. But there's certainly evidence to say that it can be helpful for individuals if they haven't responded to trials of SSRIs.
And one last question about medication, because I know we also want to talk about other stuff too, is I know sometimes psychiatrists might use other medications, sometimes called antipsychotics or other medications, maybe like a Seroquel or Abilify, Wellbutrin. Sometimes people might use an SNRI, like a Pristiq. So is that also an option if somebody hasn't done well on Prozac or Luvox, for instance, those frontline medications, and they've gotten the right amount of ERP, CBT therapy, so they are doing residential with Liz, or they're doing an IOP, or they're doing that higher level? Are those some of the other options that people have, and when do you know to introduce those?
Yeah, so the question is then related to sort of other medication strategies and maybe augmentation with additional agents. I think the literature, the studies that have been done are a bit mixed for the SNRI medications, so things like Cymbalta or Effexor. Some studies show that it can actually be helpful. Some show that they're not particularly different from SSRIs. The antipsychotic medications have also been studied. There's not great evidence to say that those by themselves are helpful for OCD. There is evidence that adding some of the antipsychotic medications to SSRI medications can be of additional benefit for some people. I think the evidence is really strongest for 3 of the antipsychotics. Haldol or haloperidol is an older antipsychotic, but does seem to have some benefit for individuals with OCD, and actually particularly for people who have OCD and Tourette's or a tic disorder. Abilify or aripiprazole is a newer antipsychotic that has some evidence in individuals with OCD, as well as Risperdal or risperidone. The other antipsychotics have been studied: Seroquel, olanzapine, clozapine. There just is less evidence that they're actually helpful for people. And I think the other thing that has come out of those trials of antipsychotic medications is that typically for OCD, they're lower doses than we'd use for individuals with schizophrenia or schizoaffective disorder or bipolar disorder. And the trial should be like a defined period of time. It shouldn't be, okay, we're going to start somebody on Abilify and then just give it like 2 or 3 or 4 months. It should really be like 4 to 6 weeks, make some dose adjustments. If they're really not getting any benefit out of that medication in that amount of time, then the potential side effects to antipsychotics outweigh the continued use. So if people aren't getting benefit over a relatively short period of time, then it's worth moving on to something else. And I'll say it's unfortunate. I hear from people and have seen people at times where their psychiatrist doesn't start them on an SSRI, just starts them on an antipsychotic, and then they on that for months and months and months or a few years and haven't really had benefit. And I think that's an area where we could try to have some improvement in terms of prescribing.
So let's talk a little bit about you engage in medication adjustments. You're not really getting better. You're still struggling with severe OCD. You're engaging in effective behavioral interventions, right? So we need to make sure both are happening before we say, oh, this isn't working for me, because we wouldn't expect medication alone to work, right? We need you to be engaging in evidence-based behavioral interventions, so ERP. So let's pretend you're engaging in both. You aren't finding the benefits, and you're kind of continuing to feel stuck. Let's start talking about some of the next options that are kind of psychiatric interventions. So one of the questions I get all the time is, does TMS work for OCD? Does ketamine work for OCD? And I have my own anecdotal thoughts and evidence, but it's not evidence, my own anecdotal thoughts, but I'm not a psychiatrist, so would love to hear from you. Let's start with TMS. So if you want to just kind of explain what TMS is, what the research to date shows and tells us, and where it might fit into the OCD treatment model.
Yeah, it's a really good question. If people, as you point out, Liz, are connected to therapy, have tried a number of medications, and just are stuck, aren't really having the notable response, I think TMS is a very reasonable next treatment option, and there are studies to support this, and this treatment has been FDA approved for OCD in just the past few years. So for depression, TMS has been approved for well over 15 years with ongoing research and new treatment coils and new treatment parameters and locations. We found that it can also be beneficial for OCD as well. A typical course of TMS is usually every day, 5 days a week. It's an outpatient procedure, so people can come into the clinic. They can drive themselves in, they can drive themselves home. There isn't any sedation or anesthesia associated with TMS. And a typical course, a typical day of treatment for OCD lasts 20 to 30 minutes, so relatively brief. And that usually goes on then for 6 weeks, sometimes a bit longer, but usually like 30 sessions is kind of a index course of TMS. And in studies that have been done, somewhere between 40 to 60% of people have a positive response to TMS. I think it's worth pointing out that these studies are in individuals who haven't responded to therapy, to medication, and so fall into this sort of treatment resistant or treatment refractory category, where we know, like, if we just tried another SSRI, the chance of that improving their OCD is very low. And so maybe about half of those individuals can experience some improvement with a course of TMS.
So would you say TMS is currently an evidence-based intervention for OCD?
Sorry, I think I missed part of that question, Liz.
Would you say TMS is an evidence-based intervention for OCD?
Yes, in the sense that there have been a number of studies that have been done in a controlled setting. So the study that was conducted or published in 2009 that got FDA approval for OCD, it had individuals with OCD at multiple different sites, and it had a group of people who were getting active TMS, and it had a group of people who were getting sham TMS. So the TMS machine, when it's active, makes a relatively loud clicking noise, and also typically causes a tapping sensation on people's heads. And so without proper control, people would know, yes, I'm getting TMS, or no, I'm not. The authors of that study provided a TMS sham group, meaning that people had the experience of the clicking noise and the tapping sound, but didn't actually get active TMS. And so these are the kind of studies that we're looking for to really show us, is there benefit from this intervention? And again, in that study, both groups had some improvement in OCD, but the group that received active treatment had a larger decrease in their Y-box score over time, and more of the people in that group were in that responder status. And there have been a number of other studies, again, supporting the use of TMS in OCD.
Okay. All right, so let's move to ketamine. And where do you feel like ketamine stands, and what are some of the updates on ketamine?
Yeah, it's a good question. I think ketamine and some of the other, depending on who you ask, whether ketamine falls into sort of the class of psychedelics or not, there's a number of sort of novel treatments that are being explored. I think the evidence for the use of ketamine in treatment-resistant depression is stronger. There are more studies out there, more controlled studies of ketamine for depression. There's fewer for OCD. The few that are there are often like single dose of ketamine, and typically when ketamine is administered for depression, it's multiple dosing, even over several weeks. In some of the studies for ketamine for OCD, that single dose has benefit for some individuals. And I believe there are clinical trials now going on of ketamine and multiple doses of ketamine in OCD. So I think we'll have more information probably in the next few years about the role of ketamine in treating individuals with OCD. I think right now we're sort of in the early days in terms of like the number of studies, the size of the studies, the design of the studies, to give us, solid information to say yes or no in terms of administering this for OCD.
I would say and maybe you alluded to it, one of the questions we get on here sometimes, and we definitely get it, or I get it a lot just at events, is psilocybin. And I just wanted to see if you have any thoughts. Obviously, people will call it more like magic mushrooms. Sometimes people might say, and I always get it wrong, not ecstasy, but MDMA. Those are probably the two that people will read something about, maybe for PTSD or something else, and then ask about the effect on OCD.
That was my next question too.
Yeah,
Twins.
Yeah, it typically comes up anytime we're talking about sort of treatment options for OCD. I think we're sort of in the same area there as we are with ketamine. There are some small studies. Often these are sort of like case reports where like a single person has a positive experience, and then that gets published as like evidence in support of newer treatments. What we really want are these like larger controlled trials where we're administering medication to larger groups of people and trying to control for that. So some people get the active medication, some people get a placebo, and I think that's where we'll hopefully get the strongest evidence, either in support of or showing us that it's not effective. But at this point, I think it's too early to say definitively yes or no. And I'm hopeful that in the next few years, again, we'll have more information to really guide us in terms of recommending that or not.
And maybe
I maybe will also say that the studies that are typically studies that are typically done for other indications, so depression or PTSD, they're typically done in a very controlled setting. There's a lot of therapy that goes into those studies, both before people get the compound. There are therapists present while people are getting the study compound. There's therapy that happens after. So those sorts of studies, I think therapy is an important component in those studies. And that's different from how I sometimes hear when people ask the question about, psychedelics for OCD. They're interested in like if they do microdosing on their own at home. And I think there we have even less evidence than in the sort of larger controlled studies that have a large therapy component.
Well, what I hear you saying so far is that, I'm going to like caveat it a little bit so you can correct me if you disagree, is that TMS is like kind of evidence-based. So we're starting to have some emerging evidence, but it would not be more evidence-based to start with TMS versus SSRIs and some of the more standard frontline treatments that we have more evidence behind for someone with OCD. Ketamine and psychedelics are not evidence-based to date yet for OCD.
Yeah, I would say I think yes, you got that accurate. That we've SSRIs, clomipramine. We've been studying these for decades now and have many studies that support their use. TMS is newer. We're still sort of figuring out the optimal way to deliver TMS. There is evidence that it's helpful for people who haven't responded to first-line treatments, and it does have FDA approval. But I think we're likely to see that space expand out in terms of like optimizing TMS treatment for individuals. And I think you're right, Liz, that the ketamine and psychedelics we just have less information, and people are certainly looking into those. But right now, I think the evidence base isn't strong enough to recommend using them.
Perfect. That makes sense. So let's hop to one of my favorites. So I say my favorites, you guys are gonna be like, why? I've just done a lot more work in this area than others. So DBS. So let's talk a little bit about the history of DBS, how long DBS has been around, and maybe you can do like a quick not presentation, but just a quick like DBS versus like Gamma Knife and some of the others, so that we are clear about kind of why DBS may be less invasive and what we know about it, and go from there.
Sure. So DBS or deep actually, and initially was used.
No, we got you back. You're good.
We got you
Did
back.
I freeze, guys? Sorry.
Okay,
sorry.
We're defining DBS, so you can start back over there.
I apologize for my internet connection. DBS's deep brain stimulation has been around for decades, really. Started in more in neurologic conditions, and then has more recently been FDA approved and explored in psychiatric indications. And so things like Parkinson's disease, essential tremor, dystonia, and even epilepsy are treated with deep brain stimulation. And then the only FDA approved psychiatric indication is OCD, and that came about in 2009. And DBS for OCD is approved by the FDA under a slightly different mechanism that puts some parameters around who can receive it, in what setting it can be administered. It typically needs to happen at larger research universities where there's oversight of these types of interventions, and the evidence base to support the use of DBSs, I think, is strong, and there have been many studies, but that evidence base is slightly different than for the sort of standard FDA approval pathway. DBS is an invasive procedure. We partner with our neurosurgery colleagues, and electrodes are targeted to particular regions of the brain. This is in contrast to TMS, where we place a magnet over a particular region of somebody's scalp and pulse the magnet on and off. There's no anesthesia, there's no surgery, nothing gets implanted. With DBS, we're implanting the electrodes, and then those are connected to a pulse generator. It sort of looks like a pacemaker. That's where some of the technology originated, and that's usually placed in the chest. And that treatment is ongoing. So once the electrodes are in place and the pulse generator is turned on, it typically remains on continuously, and often for the life of the individual. There are some studies that if people have a positive response to DBS and you turn the device off or the battery runs down, then OCD symptoms come back. That's again a bit in contrast to TMS, which is usually like 6 weeks of treatment, and if you've gotten better, then we stop treatment. We don't continue to do TMS for in an ongoing fashion. And the people who might benefit from DBS are individuals who really haven't responded to multiple medication trials, to therapy, to clomipramine, to augmentation with an antipsychotic, who have had OCD for at least 5 or more years, and whose Y-box is in really the severe to extreme range. And they're not doing well. They've got a significant functional impairment, so not able to finish school, not able to hold a job, not able to leave their house. And those are people that we start to think maybe DBS is the next step for them.
And I think what's important to note, I've been a part of a lot of DBS trials under Dr. Goodman, who I worked a lot with, is that DBS is something that it is not a first line intervention, but it's also not a last line intervention, right? So even post DBS, a lot of patients at that point can greatly benefit from ERP and then being able to further engage in behavioral interventions. Can you speak a little bit about that?
Yeah, absolutely. I think that's a great point. So typically, if people will have a positive response to DBS, and again, depending on the study, it's somewhere between 40 to 60% of people will benefit from DBS. Again, that I think it sounds like a low number, but when you consider that these are individuals who have tried every other option and are severely impaired by their OCD, this at least gives people hope. For those people that benefit, there have then been studies of reintroducing ERP. And to be able to get DBS, they would have had to have not responded from at least a one trial of ERP. And usually people that I've seen have tried ERP multiple times and haven't responded. So studies reintroducing ERP after DBS, and people are gaining additional benefit from ERP and having further reductions in their Y box beyond just turning the DBS device on. So it does seem that there can be, additive benefits to DBS and then behavioral therapies as well.
Perfect. That's
So
great.
I think important to continue to stay connected to all of the different treatment options.
Yeah. No, that makes total sense. And, I think, again, I've seen DBS. If anyone has seen any of the videos on like DBS for Parkinson's, it's like mind blowing when you see what happens. And, I've seen it be really useful for patients. But what I've really seen some of the biggest use is after being able to re-engage in OCD treatment and what that's like for them. But I'm curious and would like to hear your thoughts on DBS for tics, because a lot of our viewers do also have OCD and tics and related disorders.
Yeah, I'll mention you sort of maybe I'll start with the time course of response that we might expect with DBS for OCD, which is a bit different than, for instance, DBS for essential tremor or for Parkinson's disease. There, almost instantaneously, turning on stimulation can dramatically improve somebody's tremor, improve their Parkinson's symptoms, and it really it's almost magical. That's a strong word, but it really is like dramatic improvement. For OCD, we are typically expecting positive improvements in OCD symptoms over weeks to even months. So not an immediate improvement. Many individuals will see a faster improvement in symptoms of anxiety and depression, whether they meet criteria for a major depressive disorder, or generalized anxiety disorder, or just have some amount of depression and anxiety. Those appear to improve more rapidly than OCD symptoms in individuals getting DBS for OCD. Your question about tics, there is, I think, a decent evidence base there as well of DBS for Tourette's or for tics. The location that the neurosurgeon targets with the electrodes is typically different in tic disorders, and while there's a decent evidence base for DBS in Tourette's and tic disorders, it's not an FDA-approved treatment at this time.
Can we real quick jump in? Because I think sometimes people get, why we're on the topic of DBS, I think sometimes people get them confused. So I think it'd be good to bring in Katya's question, Amanda, at 12:46 about ECT or electroconvulsive therapy. And the reason I want to bring this up is because I know that Liz is passionate about DBS. You've talked about DBS at things. And I noticed that a lot of people who aren't in the field misconstrue DBS and ECT a lot, the electroconvulsive therapy. So, can you talk, is there a difference or is it just different terms? And kind of clear that up a little bit.
Yeah, so ECT for OCD.
Oh no.
While we're waiting, I'll kind of go through definitions. So ECT is electroconvulsive therapy. Is that right, Chris?
Yeah.
So it is very different than TMS, transcranial magnetic stimulation, than DBS, deep brain stimulation. So what we were just talking about was DBS, so deep brain stimulation, where electrodes are inserted, there is a pacemaker, and stimulation is being sent. TMS is, and that's a continuous implantation that stays and that's actively working throughout the day and throughout, right? It's continuous, compared to TMS, where there's a helmet wore that you wear during the treatment, where the stimulation is provided during that treatment, which I think he was saying is typically like a 20 to 30 minute treatment for OCD. And then of course, ECT is very different. So I just did a little explanation of the different acronyms to run people back through them, but we'll hop back into ECT. And can you explain, is ECT warranted for OCD and should people be doing it?
Yeah, it's a great question. I apologize for my connectivity issues. People have looked, and there doesn't seem to be evidence to support the use of ECT for OCD. We know ECT can be quite effective for depression and also effective for other conditions, catatonia, psychosis. There just doesn't seem to be consistent improvement in OCD when people are getting ECT. So not something that I would include in sort of my treatment algorithm for OCD.
I wanted to jump back on one other thing. It's another Katya question, but I think that these are the two other ones that I get a lot. And so I just want to make sure we cover it. So at 12:38, she asked about CBD for CBT. If you could just briefly overview maybe like CBD, THC, supplements. I think there's a lot of people that will be afraid of all the things we talked about. Because I think what I love about today's stream so far is I feel like if I'm a patient and I came on today's live, like I have a really robust amount of options and I'd feel very hopeful. I think there are people out there that have nerves about maybe side effects or beliefs about psychopharmacological interventions. So do we see anything out there on CBD, THC supplements that would warrant trusting that and using that as frontline, or is the research not there? What is the research showing us?
Yeah, it's a good question, and one that comes up frequently, often kind of in that context of like, what are the other options out there? And I appreciate, Chris, that you point out that we do have a lot of options for people with OCD. We have behavioral interventions, we've got multiple different medications, we've got neuromodulation. I'm more hopeful for people with OCD now, given the sort of variety of treatment options that we have and that are being researched. So we already sort of touched on ketamine and psychedelics, and I think we'll have clearer answers in the coming years in terms of how those might fit into treatments and treatment algorithms. I think we're in that domain still with CBD and THC in terms of like controlled studies suggesting either benefit or no benefit for OCD. It currently that neither compound features in any standard treatment algorithms for OCD, but I think we'll probably have more information in coming years about how that might be beneficial or if it will be beneficial for people with OCD.
What do you, for clinicians like Liz and I, that we're working with a client and we see that we believe that an adjunct frontline medication or some of the other options you talked about, what's the best way to kind of, there was a question by Kayla at 12:48, Amanda, but I think it's a bigger conversation. Like, how do we kind of weed through the stigma people have or misinformation to get them to really trust that these may be options for us that are helpful? Because I know in my own case of OCD, medication really helped me, but I delayed it very many years because of like stigma and misinformation.
Yeah. I really appreciate when my patients' therapists reach out or when I'm able to talk with them and that we can discuss sort of how treatment is progressing, what you guys are working on, where the stuck points are there, whether medications are involved or if we're thinking about starting medications, and sort of have a broader kind of treatment plan and goal for individuals. And I think that's one place to start, is to try to have those conversations with the other provider, whether it's the psychiatrist reaching out to the therapist or therapists contacting the psychiatrist. I think at times individuals, providers can work just past each other and are doing things that could actually be synergistic or additionally helpful, but they just don't like realize what's happening from the other side. And so really kind of like trying to come together and put the best treatment plan in place, I think is the first place to start there.
Collaborative is what I hear, which is super important.
Yeah.
Some people are going to have comorbidities. Tom Hooper at 1248 asked like if SSRIs are effective for OCPD. I know that I heard you talk about the medications and some of these other treatments have been helpful if somebody has OCD and maybe comorbid anxiety or comorbid depression. If someone's also coming in maybe with comorbid PTSD or a personality disorder like OCPD, borderline personality disorder, are some of the medications and the interventions we talked about helpful for other comorbidities like that? I know you already touched on tics and stuff. Or is it sometimes people may need to try different interventions for some of these comorbidities?
Yeah, it's a great point. Some of the comorbidities our treatments will address or will help. Anxiety, depression, tic disorders potentially as well. Some comorbidities aren't as responsive to medication, meaning people could try medication, but the likelihood that they'll get benefit for that is lower. And so, for instance, I think OCPD and borderline personality disorder and complex trauma or standard PTSD would likely benefit from more specialized behavioral and psychotherapy interventions than they would from making dose adjustments to their fluoxetine or their sertraline.
Awesome. This has been so amazing. I know we only have 1 minute, and I feel like we've covered so much. So, Dr. Frank, we didn't even get to all of our pre-submitted questions. So I know we'll want to have you back. But I think what's really important is what you just said, and I just want to highlight that. And sorry, I've been trying to look at messages and stuff that come in, but it's really important for us to recognize and understand that the most evidence-based frontline effective recommended treatment for OCD and anxiety is a combination of behavioral therapy and medication. And so we should never be thinking about medication as a sole intervention. One thing that you mentioned up front is that sometimes with patients mild to moderate, actually behavioral therapy alone may be enough and they may not need to go medication route. But we certainly wouldn't want anyone to be saying medication alone is what we should think about. And so it's really about if the medication isn't working, again, we also want to think about, is the behavioral therapy working, or should that be adjusted and shifted? So it's really about collaborative care. And that's the point of OCD and other treatment across the board, is we always want to be working together as a team. Please make sure you're considering an OCD specialty psychiatrist. Please make sure you have an OCD specialty behavioral therapist, and that they're collaborating, connecting, communicating, and working together. This is just so important to help everyone move the needle. Thank you so much for your time. It's been so helpful, so informative, and we are so grateful.
Thank you guys for having me here. Really, really enjoyed it.
Yeah, thank you so much, Adam, my OCD SoCal brother. I just want to say, really highlight what Liz said is like, please, please, please make sure, Adam talked about some great interventions. I hope it really gives you hope and it gives you an overview. And always make sure, and I love that Adam highlighted that, and Liz just exclamation point, the combination of ERP and medication, or one of these other modalities if medication doesn't work, that is what you want to be aiming for. So make sure that you are working with a team that's in conjunction. Any final thought to take us out, Adam?
Just to reiterate that I'm optimistic. We've got a lot of different treatment options for people now that we didn't have even like 5 years ago. And so I think the potential for people to get treatment that's going to help them and to have access to that is better than it was, and is hopefully continuing to improve.
Awesome. Well, thank you everybody for joining us. Liz and I are forever grateful. We love this community. We love spending our time with you. And please, please, please don't forget to sign up for the July conference. Liz and I want to see you in person. It's in San Francisco, the 7th of July, second weekend. Go to iocdf.org and sign up for that conference. We want to meet you all, and you get to have great experiences with Adam and other speakers in person. And I'm excited to see Liz.
Totally. See y'all there. Sorry. Thanks, y'all. Oh.